and maybe I'm a bit of an imposter here. But it's a pleasure for me to be speaking tonight, especially with the invitation of Samir, who is one of the best fellows we had at the Queen Victoria Hospital. I was a director there. He's now taken my position, and it's a great pleasure for me to see himself and Damien lead the department, both ex-fellows. I feel a bit like a has-been, so it's quite nice to be invited back again to participate. So I feel like I'm coming home. These are my financial interests. Nothing really related to what I'm going to talk about tonight. Maybe Bausch and Lomb and the Femtosecond laser and the Cornea laser. I need to acknowledge my wife, Marcella, and also Christian, who's put some of the data together. Now, do you recognize this guy here? This is Samir. He was roasting me on my 60th birthday last year. And I thought I'd better give him something back. So this is Samir when he was my fellow. There was a very young-looking me there, but a very young, an even younger-looking Samir with even more hair, right? And this is him. Oh, I had a picture of Samir dancing, but I thought that'd be too embarrassing. But look, he's even dressed up like me. He knew he was going to take over. Got the same colored tie and the same suit on. Samir, what is this? So did Marcella tell you about my wardrobe that night? So this is a very memorable day for me when I left when I formally left, and the Queen Victoria Hospital Cornea Plastic Unit had a party for me with a lot of ex-fellows and broadcasts from around the world. And I think I looked at the list of participants. Some of you are in this picture. And yeah, I greatly appreciate that. And this is more recently, this Samir and his wife and Marcella and myself last year when we were allowed to celebrate things. Hopefully we'll be doing that again soon. Anyway, let's get on to talking about the cornea. So my talk is about corneal sculpting. I thought it would sound pretty good. And actually what I meant to say, it's all about the shape. And actually it's not all about the shape. It's about the shape, it's about thickness of the cornea, and it's about clarity. How clear is that cornea? So on the assumption that the cornea is thick enough and it's clear enough, then it's about shape. Now in 1996, we acquired the first orb scan in, I think it was the first orb scan in Europe at the Queen Victoria Hospital. And my goodness, I learned a lot about corneal shape. Because in those days, now we're talking, I trained as a fellow in 1991. The CMS, which became the TMS, was a placido topography machine. It would take half an hour per eye to analyze. So you imagine a patient came for topography, it was a nightmare. You had to put them in, it's like coming from an MRI or a CAT scan. We had to book slots for them. And all we did was digitize the placido ring. We could tell where the astigmatism was, where tight sutures were, and so on. But when we learned about three-dimensional mapping of the cornea, then we realized elevation had a lot to do with it. And if you take a look at this patient here, post-penetrating keratoplasty, had a lot of astigmatism. This is against the rule of astigmatism. This is the negative axis. And it's because this elevation here. Now, how would you cure that? Well, you could make incisions in the graft above and below. But
yeah, sorry, are you sharing a scan? Because we can't see that. Did you advance
the orb scan? No, you can't see an orb scan?
Not yet, no. I still see my picture, thank you.
You got it?
Yeah, not yet. I think it's not advancing on the screen here.
Okay, you see the writing there?
No.
Do you see? Let me just check something out here. This is crap. Just give me a moment. I'm going to switch to. If I lose you, I'll log in again. Okay?
That's fine. No problem.
You saw the important pictures, which were of you, right? Of you and your wife. Cancel. Okay. Let's go back to this again. That's okay. Okay. So you see the writing there?
Perfect. Yeah.
Okay.
Thank you.
You see that image?
Yep.
Okay. So if you take a look, this is the elevation I'm talking about right here, giving negative astigmatism in this direction. I say you can make incisions here. That's what everybody does, but it can weaken the cornea. But this is really the culprit. So you could, as I say, make an incision. This is an AK at the slit lamp. Can you see this video? Yeah, good. So you're going to be pretty bold and be able to handle a knife pretty well to do an AK at the slit lamp. This is in the graft-host interface. There's a lot of surgery you can actually do at the slit lamp. It is a microscope after all. But you do need to maintain sterile technique. So that's why I'm spreading the incision open. And sometimes you can titrate it, see a patient again at another visit and continue. That's a residual stitch there. But I'm making two paired incisions. So paired incisions for astigmatism at the slit lamp. That's a bit of a better view there. And following the graft-host interface rather than trying to create something new. So in these old grafts, when we use a tree find, they would undercut. So you just have to bear that in mind. So that's one way of doing it. The other way of doing it is using modern technology. So this is a Victus Femtosecond laser with online OCT. You can see the graft-host interface right here.
Sorry, it's not advancing again.
Well, where would that be? Can you see the video now?
Your video started with the arcuate incision, but did not finish, just frozen there.
Oh no, so is it moving now?
No.
So is it, can you see anything going? There's still...
It's frozen at the AK at the slit lamp.
Oh, really? So let's go back to this. That's one of the problems with Zoom. You can't have a fantastic time with videos, huh? All right, let's try that again. Can you see it now?
No, I think your screen frozen.
My screen is frozen.
We can see your photo, yes. That's videos, okay, but your presentation is frozen.
Can you see anything there?
No, maybe if you exit and share again.
Okay. I'm on a very rapid connection at the moment. Let me just check my network preferences here. Yeah, I'm connected to a rapid 100 megabytes, so it's fast. Okay, let me just do that again. So share again. Can you see the screen now?
Not yet. They started screen sharing.
AK set that? No?
Not yet. No.
How about that? No, you don't see anything at all?
Nothing.
Do you see anything?
Black screen. It's not started your presentation.
That's strange. Stop share. Share screen. Let me try sharing my desktop. Desktop 2. And let's go for desktop 1. Can you see that desktop now? Yes?
No. No.
You don't see anything at all?
No. It's not sharing the screen probably you're presenting. Maybe did you select that screen presentation? Okay, now yes, you can see that. We can see the live video now.
You can. Okay, good.
Yeah, femto laser. Yeah.
So you see can you see this is the graft-host interface right there. So we're using online OCT to measure how deep the incision is going to go. And this is intrastromal. You see there's a yellow gap there. So what we're doing here is we're not going through the anterior surface. We're going to go inside the cornea, do an intrastromal astigmatic keratotomy. And that works quite well. Then you don't have this great big gapes, and it's a lot more predictable. And if you need to titrate it, you can, again, at the slit lamp, just open it up with a pair of forceps or a Sinski hook. So this is the great thing about lasers. You can edit how deep you want to go. This is older software. The newer software is a lot faster. Everybody both look pretty satisfactory. We're going 80% depth and 10% into so just below the epithelium. And then off we go and press the button. And it happens fairly rapidly. So if you can look on the screen there, you can see the incisions being made. And that's it. Another approach is to do LASIK. Now, can you see this screen? Yes? Yeah? Okay. So here, what we did was we crafted a way of, so this is a patient who's -6, -6. Now, if you did a traditional laser treatment, it would remove a lot of tissue in the middle of the cornea, but it would still, it would not address the area of elevation. So what we could do is to change that. Actually, that should be a +3 then. So actually, no, this meridian is -9, -3 at 25, and this meridian is +3. So if we treat bitoric treatment, so you take the cylinder and you treat half in negative mode and half in positive mode, then you can get a better outcome by addressing that lump there. So this is the kind of the sort of corneal sculpting I was referring to. So this is a patient where we did a cylinder division. I wrote a bit of software to be able to make this easy, and I can give it to you on FileMaker. If you use FileMaker, I have a FileMaker file, and you can plug in whatever you want to do, and then you do it in 2 treatments: myopic astigmatism mode and then hyperopic mode, and you can divide it up into whatever percentage you want. So this is the same patient with if you take a look at this here, you can see the astigmatism, the elevation above and below, and you can see that's a lot more respectable there. And again, you can do LASIK this is the LASIK on a deep anterior limelic keratoplasty, and to avoid transecting the graft-host interface, you can make the flap within the graft itself. It's a small flap, but it's a very satisfactory way of doing this and resculpting the cornea. Then you don't end up getting any surprises from changes in the graft-host interface. Now, the problem with this is you really do need to be a fairly expert LASIK surgeon to be able to manage these. You can see there's a few areas of bubble breakthrough there. And I don't let that bother me too much as long as they're not in the center. But they can lead to tears in flaps. That's a thin flap. So something just to be aware of, and to be quite ginger and to open the flap quite gingerly and then treat. Just checking the pachymetry to make sure the flap's the right length, and off we go with the laser treatment. And you can see it's all confined to within the graft. It's not going out to the periphery. The flap is within the graft as well. So there's less layers and so on. So that's LASIK within the graft. So let's get on to some other things now. So we use a lot of lamella techniques. I started doing lamella transplants on a regular basis from 1997. And that's when I realized actually we could do a lot better with newer techniques. And this is something that can be used for stromal opacities and also for shape change. So a lot of deep anterior lamella keratoplasty is done for keratoconus and other ectasias, and also irregular astigmatism. Now, what happens in this sort of situation? This is a patient that had a PK 10 years earlier. He's a doctor. And this is a Visante showing the thinning is not in the graft, but it's in the rim. And he was sent back to us by his optometrist saying, look, he's got keratoconus again. Well, yeah, he's right. He has got keratoconus, but not in the graft, in his peripheral cornea, where the surgeon may have missed the cone. That's what we used to think, but we realized actually the peripheral cornea is still quite elastic and probably should be, in young people, be cross-linked after doing a DLK. Now, Troutman described a wedge resection by taking away a bit of the graft. That doesn't make any sense. If the area that's offending is in the host, well, really, that's what you should be removing. So this is what we started to do at East Grinstead many years ago, and it worked quite well. So this is a series of images just to show this being done. So we're taking away, we marked out the eye, we're taking away the peripheral host rim that's ectatic. And once that's removed, you can see the Vanna scissors removing them. Then we suture it down. Now we started off using nylon. That's not a good idea because nylon is an elastic suture. It will stretch. So what we then did was combined nylon with merceline and realized that was not bad, but they still slipped. So now we just use merceline. And merceline is good. We can take out 1 or 2 stitches, but they always wind up, if you take out all the stitches, they always wind up going against the rule again. So it's probably best to keep them in for as long as possible, if not permanently. and mostly it doesn't break down, it doesn't hydrolyze like nylon does. So this is a wedge resection in one of our patients with 10 diopters of astigmatism, and this is post-op at 1 month with 2.5 diopters. So as you can see qualitatively, the power map shows a reduction in astigmatism, but still within the rule, with the rule. And this is another patient. So that's a wedge resection is another option. But what about when you've got a thin rim, 360 degrees? What do you do then? Well, if there's the anterior chamber is deep, and this particular patient was changing her glasses every 6 months. Her refraction would continue to change. It was driving her crazy and emptying her wallet. So what we decided to do in her case was a 360-degree wedge resection. So we use a 10mm trephine the cornea down to about 75% depth, and then we resected the whole wedge 360 degrees. So we dissected all that. You can see this here. And removed, so this is the dissection taking place from the peripheral incision to the graft-host interface, and then using curved corneal scissors like you do a corneal transplant, remove all that. So you can see there's a whole wedge of tissue that's been removed, and then we sutured it down. And I thought, after surgery, I thought, oh my God, what did I do? Her corneal keratometry went from 50 to 30. She had a 20 diopter flattening. But that's okay. That was soon after surgery. Over time, as she healed and we took the sutures out, she went to 42. And then she developed a cataract, and that was okay because by the time all the sutures were removed, she had hardly any astigmatism, and we did a cataract operation. So this is a wedge resection being done. I think probably just speed it up a little bit. So we're just measuring how much we needed to do, and this is the trephination, and this is the dissection. This is where things are getting a bit tricky because it's thin. You have to be really careful when you get to the graft-host interface, because if you break that wound open, then that's a bit disappointing. To try and, as Samuel will tell you, to try and dissect a soft eye is not the easiest in the world. So you really want to avoid perforation. So here I'm actually going into the graft itself and carefully using a crescent blade dissecting. Now I wouldn't make this your first wedge resection. You need to have quite a lot of experience in doing this. So the simple wedges are probably the good way to start. And once you get confident with that, then you could consider this. But remember, you can't do this in every patient that's got thinning 360 degrees. They've got to be ectatic, and they've got to have a deep anterior chamber. So I won't bore you too much with that. So suffice it to say, we accomplished that. And this is a speedy surgeon at work here. And that's a resection taking place right there. And you see, I'm just cutting at the graft-host interface. And this is the sort of case you just take your time. You know, you want to reshape this cornea for the patient's best, for a good result for the patient, without having to do a large PK, because that's what we were taught to do when I was doing my fellowship. They said, well, you know, got this irregularity, you just do a bigger PK. Well, bigger PK, I mean, that increased chances of graft rejection, glaucoma, and so on. And although her endothelial cell count was only about 800, she was tolerating the antigens. Why would we want to change that? Might as well just keep the endothelium in place, her cornea was clear, and instead do this 360-degree wedge resection. Another option is to, because they've tolerated the endothelium, is to do a DALK on top of a previous PK. I don't know if Samir has been doing this and showing off his fancy techniques, but I think he was a co-author on this paper. So hopefully you're practicing what you preach there, Samir. So there are some tricks in doing this. This is really advanced keratoplasty, yeah? And the key is you find that the Decimase membrane is very easy to remove on the graft, but the graft-host interface, if it's not been sutured properly, if the fellows who did the graft didn't learn how to suture well, then you could land up really perforating because you've got this ectasia, the graft-host interface. So it's very important, especially now with OCT, to be able to image the whole corneal interface to make sure there's no areas of ectasia there that could perforate, and if there are, mark them at the slit line before you operate. So this is one of my first patients I did in the year 2000. So 21 years ago, and I still see him today. you can see the old graft and how small it is. You actually almost missed the cone in his case. Here there's a superior cornea, and he had, keratoconus is inferior. So we did a DLK on PK on him, and he's done very, very well. He has 6/9 unaided vision in that eye after a cataract. So this is this is the paper. That's Samir there. This is the paper that Damien wrote, looking at our series of patients. So this is that's DLK on a previous PK. So what's the advantage of that? It's technically challenging, but that patient has tolerated those antigens for over 20 years. Why would we want to replace them? And why would we want to replace them with a large graft when you have a large lamella graft that's probably going to be tolerated very, very well? So this is another ectatic disease, pellucid marginal degeneration, right? Pellucid meaning clear, marginal in the periphery, degenerating. The same sort of pathophysiology as keratoconus. Well, we decided to do something similar here, and this is a paper we published on performing a wedge resection and lamellar dissection for pellucid marginal degeneration. So basically what we do is a facelift procedure. So here we're removing the ectatic wedge. So using a micrometer knife, cutting down, and in order to, if you take a big wedge out and you just suture it, you're going to get striae in the posterior of Descemet's membrane right through the visual axis. So how can you avoid that? Well, you can avoid that by splitting the cornea at Descemet's membrane, and then you've got a space there. So you can. So this is what we're doing here. So I've removed the stroma of the wedge, and now I'm dissecting that cornea fully. Once the cornea is completely dissected, then we suture the cornea. This looks like a repetition. So once we remove that, we can suture the cornea. So we're sort of mobilizing the anterior cornea inferiorly. It's a bit like an inverse facelift. And that looks like an egg-shaped cornea. That's exactly what we want. And believe it or not, that will slip backwards to almost emmetropia. Sometimes to no astigmatism. Sometimes it goes against the rule as well. And this is an animation done by my nephew, who tried to illustrate the whole process, because it's kind of complicated to understand. So what we've done is we've got the ectatic area there. We've made the wedge section. We've taken off Descemet's membrane, removed the wedge, and then sutured down the cornea. And once the cornea is back in place, we use a big bubble to push the Descemet's back up again into position. And that works quite well. So this is the procedure. Again, I'm going to speed it up a little bit. So using a micrometer knife. And this is where you're going to be a bit like Zorro and be able to cut a nice semicircle, quite a large one. In this case, I think it's about 5 clock hours, 4 clock hours. And you got to do it twice. You got to do a wedge. So you can see me taking the wedge there and hoping that I make the turn. No overturn or underturn, or I'll be off the road. And that's it. So my old RK days and AK days came to some use there. And here in this particular case, I'm making the incision with the same diamond knife. I know I can go deep enough with that. I can't remember what I did in this particular case. So here's a paracentesis I use Melis's technique to decide how deep to go. So there's a bubble in the anterior chamber. And with Melis's technique, you can identify how deep you are with the stroma by using this instrument, as you'll see me do now. Oh, actually, first I'm taking that wedge away. And that just peels off. And I started dissecting inferiorly, but I realized that probably wasn't good enough. So we decided to go superiorly. And here we are. These are some spreaders that we invented. That wasn't working. So we used the Melis dissector right there to dissect the whole cornea. So once that's accomplished, you can see there's a bit of blood there. We've got to get that. We don't want to leave that behind. So I do flush that out. But you can see there's a wedge there. So I basically undermined the whole cornea. And now I can suture that cornea. So it's really like doing a facelift, right? But the other way around. Now I suture that cornea with merceline sutures. Oh, that seems to stop there. Well, anyway, we sutured that up, and this is what it looks like. We inject an air bubble, push the Descemet's back up against the cornea, and this is what the patient looked like afterwards. You can see a whole series of merceline sutures in place, and he did very well. So this is an example of a pellucid marginal degeneration with a wedge lift and inverse facelift. This is pre-op, and this is post-op, showing a marked reduction in astigmatism and a more normal-looking cornea. We analyzed our data, I think it was in 8 cases or 10 cases, I can't remember the number, 8 cases. And this is the preoperative in blue bars and postoperative in visual acuity, best corrected in red bars. And you see they all did very, very well, with almost all of them 618 or better at 12 months, and more than 50% 612 or better. 612 in all of them, and 6 of 7.5 in 50% of them at 12 months. Can neurotechnology help in accomplishing the same thing? So we have femtosecond lasers, but why not use those? And we've got OCT guidance on these lasers. That's a really great help, and it's a lot more precise. You can cut perfect circular cuts and elliptical cuts with a laser. A lot of what you can do is actually limited by the software and the basic interest of the manufacturer, because every time they do make a change, they've got to go to the certified body, and they've got to go through this whole process of justifying it. And there are ways around it, which they sometimes use. It depends on how enthusiastic they are. But anyway, this is a patient who is from Afghanistan, who is wearing scleral lenses, and he came to see me because he had pain in his eye. He couldn't wear his scleral lens anymore. And I saw him 6 weeks after the pain started, and it was getting better. And when I took a look at him, he had extensive pellucid of more than 6 hours, and he had high drops in the pellucid. Now, I've only seen that twice. So I thought, well, 6 clock hours, I can be a good Zorro, but that's a lot. And he was very, very thin, as you can see in this OCT here. And this is 250 microns here. And this was thick because he had high drops, which is now healing, and it was thickened in one area. So, I've got a bit of a wedge resection in an area that had high drops. The thinning goes all the way out to the limbus. This is going to be tricky. So we use a femtosecond laser in this case. The important area to cut is actually central. You want that quite circular. Peripherally, if it didn't work, I could always cut it with a knife. So this is you can see from the software, this is an old version. I think it's one of the earliest versions of the Victor software. And this is the video of it. So we're using this, and I got to tell you that there's a lot of playing around. This is heavily edited. We had to go on and off the eye to get the actual dimensions correct. It's a lot easier now with the laser, but at that time we were doing AK incisions of 180 degrees, and we're doing them like tram lines. So that's the central area done, and now we're doing the peripheral area. So now we've got a rail track. So what am I going to do? How am I going to put, like a rail track together? Well, it's very easy. I can, learning from plastic surgery, you can make a little, so you can see this. There's a rail track on one side, and then on the other there. So I'm injecting a bubble. I'm doing my old technique, making an incision superiorly, and dissecting again. Now I know this cornea is pretty thick, so I can go at it. This is a speedy up video. I don't operate that quickly. I'm not as fast as Summer. Now I know this patient's got high drops, so I pull that up, and I start where the high drops was, because I know there's going to be a deficiency there, or a very thin Descemet's membrane. And this is using a bit of Vaness dissection, dissect that wedge just above Descemet's membrane. And now you'll see me peel this off. Now look, this is a speeded up video, so I might look a bit rough, but I'm not being rough at all. Well, you see how that bubble just went? Well, I know there's a hole there, and there we go. Well, that's okay. I've done all the dissection. The hole is right at the end. It's a soft eye now. I can take that wedge off. And you know what? I'm going to invaginate that that Decimase membrane into the anterior chamber, and that's going to seal the hole. So I'm not too concerned about that. Sometimes when you have a hole in Decimase membrane, you worry about a double anterior chamber. Remember, I've taken all this Decimase membrane off. But if I've sealed the hole, I don't have to worry about a double Decimase membrane either. And that looks horrific. But let me tell you, these sutures have to be tight. The first sutures are always look miserable. But once you got them all in, it actually looks quite nice. And yes, I want him to have astigmatism in that overall direction. I'm not sure what direction that is because it's 6 o'clock hours, but I want all that to be tight. And I like him to get fibrosed. So this is, I didn't have a picture of him. Where'd that go? So anyway, so that's using the femtosecond laser to correct pellucid marginal degeneration. In his case, he kept actually slipping, and I cross-linked his residual cornea, and then it stopped. And his promises to come back from Afghanistan. He emails me every so often to have his other eye done, but he manages without a scleral lens now. He actually has good unaided vision in that eye, and uses glasses with a scleral lens in the other eye. So that's regularizing the cornea, a bit of sculpting with a laser, a bit of reshaping, a bit of facelifting here and there. There's actually plastic surgery on the cornea, and it's all about shape. So when you're evaluating a patient, start from first principles. So before I became an ophthalmologist, I couldn't get into ophthalmology. I had to do internal medicine, and that was again in the United States, where they teach you to approach things from first principles, and I've applied that here. All right, so somebody's got astigmatism. What's causing it? It's the shape that's the problem. What's influencing that shape? Is it ectasia? Is it an graft wound slippage? What's going on? And is that cornea thin or thick? And is there anything that I can do which is less compromising to that patient that regularizes the shape? So to me, doing a repeat penetrating keratoplasty is a terrible thing to be doing. I can always leave that as a last resort. Why not do other things on these corneas to get them shaped up, get them in shape so they can see? Thank you for your attention.
Thank you, Sheraz. That was fascinating, actually, and eye-opener to what possibilities, which are endless possibilities here. Great. I mean, I have to say I enjoyed the videos, and I observed you live surgery all the time, but yeah. So can I just go back to the Femto AK, which you showed earlier? So yeah. It's intrastromal, basically, cuts. Mm. Do you tend to enhance them? Do you complete the cuts if need be? And how you decide how much is enough?
Yeah, so I started doing that because when I made cuts, either with a knife or with the femtosecond laser, the femtosecond laser is great because it goes round deep, as deep as you want. Mm-hmm. I found those patients on day one were great, that one diopter of astigmatism, but they came back in 3 months with 6 diopters going the other way. Mm-hmm. So it was a bit too effective. Mm-hmm. So then I started doing intrastromal. So that's good because then it gives me the option of opening up that incision a little bit, titrate it if I need to. And actually, I've titrated 1 incision since I've been doing intrastromals. Mm-hmm. And it's less aggressive doing it this particular way. Okay. So all you're doing is cutting just inside the graft. In fact, it's actually involving the grafter's interface slightly, and it just allows it to lift a little bit. And the important thing is not to be impatient. A lot of people want an immediate result. They want to see a result the next day. If they've got a really good result the next day, I get really worried that they're going to keep changing and then have a not so good result in about 6 weeks, 6 to 12 weeks. Mm. And I'm sure you've seen that yourself.
Yeah. Do you do the same when you do cataracts? Like
no, when I do cataracts, I will do about 30 last time we measured was 32% of our patients required a limb relaxing incision. And again, those things are very, very, very effective. So my nomogram has been adjusted. It's based on, actually I don't have it written down, I should, but it's based on age and amount of astigmatism. But I go right out to the limbus. Mm. So with a femtosecond laser, it's very easy. You can map out exactly where you want to put the incision. So I go just inside the limbus. And that's good because we know that becomes scarred and much more stable. So those patients are a lot better. If you go too central, then in time, their astigmatism can change. And I'm sure you've probably seen that. If you go peripheral, within 0.5 millimeter of the limbus, you're much better off.
It's more controlled. Yeah. How much astigmatism would you correct, say, with that?
So what, with a graft or with
cataract?
With cataract surgery, I only go to about 1 diopter, 1.25 diopters. So the reason why is because it's less predictable and it's less effective. When we map this out again, I have a great scattergram showing a complete. You've got the attempted versus achieved, right? And it's great to begin with. Once you hit 1.25 diopters, it starts to lower, flatten down.
Yeah.
Now patients come because they want good vision correction. The only way I'm going to reliably do that beyond 1.25 diopters is with a toric lens.
Sure. And would femto cut well if there is if the limbus area is not really clear, if there's some vascularization, some pannus formation?
It doesn't do badly. You know, if you can, I suppose the rule of thumb is if you can see it with the OCT, if you can see the whole cornea with the OCT, you can probably get through that cornea.
Okay, amazing, amazing.
Certainly with our laser, I can't speak for other ones.
Of course.
The only other femtosecond laser I've used besides intralaser is the Lensex for a very short time. We weren't very satisfied with that laser and went to Victus for our second sight.
Sure. And while we're talking about that, I mean, you should. I remember when I worked with you, you were always looking for precision, and I think that's the reason why you were one of the earliest to adopt femto lasers, because you want everything to precise to the micron. And what do you think? Do you think wedge resection can be? I know you showed some videos, but just the simple classical wedge resection can be achieved with the femto, all of it, without doing.
Yes.
Yeah.
You can do that. I think they don't make the big challenge there is trying to figure out the curvature. So what I try to get Balshanam to do is say, well, you know, look, put a curve in there and let me adjust the curves. And we can do that, but regulators won't like it. I said, well, you know, I want to map it out as I wish. So what I do now is I do 2 tram lines, and then I join them up with a blade. I'll join the 2 together, and then I can close them up. Otherwise, you get a dog ear on either end, and you don't want that.
No,
it will eventually go away, but it doesn't look very good, and the patient will feel it.
Of course. I mean, amazing what you showed also about the Pellucid, because I think all cornea surgeons agree that Pellucid management is one of the most challenging, because you don't want to do graft in the periphery and there's all the issues around it. So to manage to do that with wedge, and I think the way you showed with the femto, really precise and give you some accurate results, which is great. Well done. I'm moving to the second thing you showed, the LASIK on a graft, the flap you declare flap. Now people always say, what shall we do to correct the refractive error on a graft? Shall we go for a PRK or do LASIK? And so what you, I know some of your thought, but I'd like to hear from you for the audience benefit as well.
So
would you, if you want to correct refractive error on a graft, would you go for a PRK or LASIK?
I don't do PRK on grafts. I think it's a bad idea. I don't use mitomycin C, as I told you. I think that's a terrible, terrible drug. It's dangerous, and I hope I'm wrong, but they're already picking up ciliary body adenomas from mitomycin C use from 15 years ago. And if it was a relative of mine, I would not use mitomycin C on them at all. The only time I use mitomycin C is in therapeutic treatments of the cornea where they've got irregularity, a bad LASIK flap or whatever. And again, I've not had to do one of those for a long, long time. So I don't do PRK on grafts. I think it's a bad idea. You've got a nice pristine graft. You really want to leave it alone. And even LASIK, if I do it, I will use a femtosecond laser within the cornea. But I need to evaluate these patients. You know, if their cornea is thick enough, if it's a lamellar graft and it's stable, and I know it's stable, then I'm happy to go ahead and treat if they've got a refractive error that would benefit from it. More and more inclined, though, for most of these patients, they're usually myopic, right? They have myopic astigmatism rather than hyperopic astigmatism. If they have mixed astigmatism, they do really well with LASIK with a flap within the graft. But if they have myopic astigmatism, I'm sort of drifting more towards using ICLs in these patients if it's up to 6 diopters. And that works very, very well. You know, it's an additive procedure. We're not touching the cornea at all. And we can do this. One of the reasons why I've steered away from LASIK is because I've seen these patients. I've been doing LASIK now for almost 30 years. And I've seen these patients that I did LASIK on old grafts come back with peripheral ectasia in their host rim from the blade keratomes. I can show you some horror stories as well. I've got a great video on a lot of great videos on LASIK using keratomes, especially in grafts. And yeah, they're slightly embarrassing, but I have no problem. I'm old enough to show them now. So maybe I can do a talk on my refractive journey sometime in the future.
That's going to be another session for. I'm sure we're going to have you with that, Sheraz.
Yeah. So eye seals are a good option, and I think if you leave the cornea well alone, you're better off.
Okay. Can I ask a question? I'm sure you came to see those cases. They refer to you for irregular cornea. These are not graft patients. This patient got extremely irregular cornea for various reasons. Would you consider the femto procedures, I'm talking about like incisional procedures, to correct their irregularities?
No, I think that, I mean, it depends, you know, it's like the heart rhythm. Is it irregularly regular or regularly irregular? Now, regularly irregular is if you've got, you know, an asymmetric bow tie, right? If it's got an asymmetric bow tie or a non-orthogonal astigmatism, well, again, question is number one, why do they have it? If it's a virgin cornea, they may well have ectasia, right? Now, if you make incisions in a cornea that's got potential for ectasia, you're just going to make them more ectatic, right? Sure. So that's not a good idea either. Yeah. So I suppose you have to ask yourself the question: why do they have this? You know, why do they have this funny shape? And then address that. So if it's a virgin cornea, in all probability they have an ectatic disorder. So cross-link them, and then decide what you want to do. Right.
Good point.
At least you stop the process from taking place. If it's irregular, then I think they've got no option but to do a graft of some sort. It could, you know, again, one of the causes of the irregularity is it because somebody's done botched laser surgery before, or do they have a herpes simplex scar or some sort of dystrophy? Well, you know, then you need to address that. And what level in the cornea does that involve? And I know you do a lot of homoplastic automated keratoplasty's or SALC or whatever you want to call it for those conditions, and that works. That's a very good option. Gives them a nice pristine surface.
Excellent. So we have a few questions. I'll just finish with, I have a couple, Artemis, then you go one from the floor. There's question here, say, which tomography machine now can you use to guide, I'm assuming, PMD wedge excision with a wide view of measurements up to the limbus?
Well, all the newer OCT devices, the Tome, whatever they call it, the Cassia 2, the one from CSO, the MS39, the Anterion from Heidelberg, the ACE from Bauschelmann, which is really the Anterion, but with a few extra features. They all do it. They can all guide you. And you know, they're very useful because you can actually map out the clock hours. Just remember, when a patient lies down, they often intort. So you want to take a look with a placido ring as to where the astigmatism, the maximum point of the astigmatism is. I actually prefer to mark the eye at the slit lamp before I take them to surgery. So I map out which area of wedge I'm going to remove, and then I take them to surgery, and then I make the incisions right there.
Excellent.
And that's useful even with a femtosecond laser, because you know what you have to encompass the wedge. So you make the tram lines around the wedge.
Okay. Can I finish with one question, Artemis, and then I'll leave you to ask the remaining question and then conclude. Just a question here about brittle cornea. I mean, we shared care of a few patients with brittle cornea in the past, and to be honest, I've just seen only last year 2 children from Middle East, Jordan and Palestine, with a brittle cornea. They're really challenging cases to do. And I remember when days of my fellowship, when we done those DALC on a PK, etc. And always the teaching was, this is like you're getting a scaffold basically. You can after that you just adding structure here, because in the future you can do more and more. So just a bit of what do you think about how you manage those brittle corneas where the cornea is like 100, 150 micron, they keep perforating stuff?
Yeah, I know. I've done them. I had a patient from Israel that was, he had keratoglobus, and with multiple eye drops and it's 17 millimeter cornea. It is the whole cornea stretched out, and he was diagnosed when he was a toddler at Great Ormond Street. Well, that was hard work, but we managed to dissect it. Now the difference between brittle cornea and him was I could actually pick up this thing and it would just peeled. Whereas fibrosa I had to dissect, but a lot of it peeled off. It took a while, and I did perforate in some places. But when I slapped on this big graft, I managed to get it. Actually, I put a 14 millimeter graft in a 17 millimeter hole. So I compressed that cornea in and injected a big bubble of air. He's done very well. And I did that in both eyes when he was 16 years old. So it can be done, but boy, with a brittle cornea, it is brittle. I mean, when you pick it up, it just breaks into pieces. It's very, very difficult to deal with. So, and even when you dissect them, I mean, they're not easy. You just have to, take your time. I mean, one of the things that you could do also is, if they're that thin, is just remove the epithelium and stick a cornea on top, because you're talking about a situation where they perforate, they get infected, they lose their eye. Well, it's better to have some vision, even through a cornea that's brittle and cloudy and has previously perforated, by having a great big, thick, fat cornea on top. And then worry about things later on. Maybe later on, in years to come, when they get much older, you could do a femtosecond delec. We can do that now with our laser. You can cut from underneath, remove that central area, and you only need to take out 6 millimeters and put another 6 millimeter layer in, and then they've got a clear visual axis.
And that is like a staged lamellar approach, isn't it? Lamellar.
That's right.
Yeah.
Also, they've got those endothelial cells drop out, their own endothelial cells, as long as the apposition is good, their own endothelial cells will migrate across into the central area and they'll stay clear. But that's really for adults rather than children. Children, I think, it's all you're doing is patching them for later, and hopefully they won't get too amblyoptic in the process.
Exactly. Thank you, Sheraz. From me, I could ask you for hours and hours. We don't stop chatting. Yeah, I'll leave Artemis to continue with some questions here.
Yeah, so we just have a couple of questions from the audience. One of them is, how can you go peripheral enough with your femto docking? And that's for Pellucid marginal degeneration wedge excision.
Well, I mean, our laser goes out. You can see the docking there. You can see the limb. You can see the sclera. So the docking, I think, is at 19 millimeters. So you're well outside the cornea, or 17 millimeters. I think they have two different sizes, one for Asian eyes, one for everybody else. And that's big enough, plenty big, goes outside the limbus. So the docking is not a problem.
Okay. And would ICL work well in a grafted pseudophakic patient as a piggyback?
Yeah, I've used them, but I think it's kind of an expensive option. ICLs cost a lot of money, especially toric ones. You can easily put in a piggyback regular lens in a patient who's pseudophakic and needs correction. The challenge is in using, if they've got astigmatism, some of those lenses start spinning around. So what I do is I'll use something like the Sulcoflex. I'll open up the anterior capsule. I'll cut off the haptics, the long octopus-like haptics, and I just stuff the optic into the bag. And that never moves. It's oriented in the right direction, and I just put the optic into the bag as a companion to the other patients. So it's not in the sulcus, it's a piggyback in the bag at a later stage, and that works quite well.
In terms of rotational stability, you mean it's...
Well, it won't rotate because it's stuck. It's the optic capture. And I did that on patients where, I had this propeller syndrome. Every 3 days, the vision disappeared for 3 days, and it was ridiculous. So I didn't want to take the lens out of the eye. I just opened up the capsule and pushed the bits in. I realized the haptics were in the way, so I just cut the haptics off. And it was fine. So now I do that on patients. So I think it's a better option. It's less expensive, and it's fairly elegant. It's not, now what I've just said to you is not per instructions for use, but I'm not a consultant for the company, so it doesn't really matter. There are many ways to skin a cat.
Yeah. I mean, the ICL as well, I mean, this benefit of the audience is for the regular cornea, isn't it? It's not for any cornea, because people get the impression that any astigmatism you can correct with ICL as well.
No, yeah, you've got to make sure that with spectacles they can see. And if they can, then the ICL is a good option.
Excellent, thank you.
And which lens would you recommend as a piggyback in this scenario? What's your preference?
Well, it depends on what the problem is. If it's purely spherical, then I would use any spherical lens I could find. If it's toric, then I'll probably use something like Sulcoflex. Toric, we'll calculate it correctly, and I'll use that. And that, as I say, we should probably put our series together, but I put a lot of these toric Sulcoflex lenses in. So when we had trifocal lenses, it took about 5 or 6 years before they brought out toric trifocal lenses. So we started doing them in 2011. And until then, what would you do with these toric patients? You could do bioptics and do LASIK on them. But I didn't want to do that. You know, they're in the elderly, you know, women in their 60s, they've got a dry eye. I'm going to give them a drier eye. So what I did in those cases was I would do at the same time, I would put a trifocal lens in the bag, and I'd take a Sulcoflex. So I had a bank of plano Sulcoflex, but toric. So plus 150, minus 3, plus 1, minus 2. And I had a bank of them sitting in on our shelf, and I would use those in conjunction with the trifocal lens. And that worked very well. And that's why I had these propeller syndromes. I realized I had to stabilize the lenses in the eye, and I would put the optic into the bag.
Nice.
What do you use, Samir?
Well, sometimes we use the pricey option as ICL.
It's life.
Yeah, I think there is one question still.
Yeah, it says, would you put a multifocal lens after cataract surgery in a grafted eye post LASIK?
Give me the gun, I shoot myself. No, I wouldn't do that at all. No, you don't want to do that. Look,
Sheraz, I think they're hinting that your grafts are so perfect and you fix it with the beautiful LASIK, so they should have no high order aberrations.
No, it's never that perfect.
Okay.
So these, you need to just think of it. You've got an abnormal set of optics with a multifocal lens, and you've got an abnormal set of optics with a grafted eye, and even more abnormal with LASIK. So I do trifocal lenses in post-LASIK patients all the time. I did 2 today, and they do very well. We have our way of calculating the lens power and so on, and they do very, very well. But as long as they have no aberrations and they got good corneas and have no ocular surface problems, I have no problem doing that. But in a graft, I wouldn't put multifocal lenses in graft patients at all, because things will change in the future, and they need exact correction. The astigmatism has to be less than 0.75 diopters to see well. You won't get.
They have like a DSEC or DMEC, Sheraz?
Yeah, they could. That's already been reported by Frank Price and others, where they have done. Well, they've either put in a trifocal later, or they've done a trifocal and the patients had a decompensated cornea, they've done a DMEC, and they've done very, very well. And they've even topped it up by doing a PRK, a transepithelial PRK for refractive errors post DMEC and DSEC. So yeah, I think that when you have that kind of refined surgery, that's fine. But when you've got a PK, which is what we were talking about earlier on, yeah, I think I wouldn't do it. I would do a multifocal lens in somebody with Fuchs that has a DSEC. I would consider it. I haven't done it, but if they really wanted it, I would do it.
Great, thank you very much.
Maybe I would put a piggyback trifocal so I could take it out if it didn't work.
That's even better option, isn't it? Safe one is good. Excellent.
Okay, so I think obviously Mr. Daya has such extensive experience. We can bombard him with questions for all night, really. But I think we need to wrap up, and we need to thank Mr. Daya. That was a very, very impressive talk and very interesting videos. So what I will do, I'll just show you our next webinar. So save the date. It's on Wednesday, 14th of April. And Mr. Mohammed Al-Alfi will welcome Professor Harminder Dua, speaking on DALK, DMEC, PDEC, science and surgery. So thank you very much for tonight, Mr. Daya and Mr. Hamada. That was really interesting. I think we all enjoyed it very much.
Thank you, Sheraz. That was amazing. Thank you so much for coming today.
Thanks for including me.
Thank everyone for listening and joining us tonight. Thank you. Good night.
Well, bye-bye.
Bye.
Thank you all.